body while the rest of the body is starting to get better. So there's one version of ECMO that takes blood out of the venous side of your body, then pumps it back into the arterial side under a huge amount of pressure. So it takes all the blood out before the lungs, squirts it all back in after the heart. Both the heart and the lungs are completely replaced by the ECMO circuit. The other side is veno-venous. It takes blood out from the atria, fills it with oxygen, and squirts it back into the venous side before it ever gets to the lungs. And so that's people with H1N1, people with end-stage lung disease, just need lung support and not heart support. And the results for those two things are a bit different, but they're both pretty good. So this was the circuit we all started with. This is a regular heart operation where we have a cannula sitting in the heart, taking the blood out, a cannula sitting in the aorta, squirting the blood back in. This would be torture to transport, right? No one would walk up to someone who is coding, crack open their chest and throw these cannulas in. That doesn't happen anymore. Now we have this. So we have long cannulas that are percutaneously inserted, just like an IV, right through the groin, goes into the femoral artery. The cannula is maybe about 1 foot, 2 feet long, sits in the iliac arteries and squirts all the blood in from the legs heading up towards the head. The venous line goes in through the femoral vein and goes all the way up to the atria. So that takes a little bit of skill to place right. You can usually do it just by feel. So you can feel when the wire is hitting things, and you can feel when the cannula is going through, but a big learning curve for that, which is why the longer you've been in an ECMO center, the better your results get. Early centers should do this all at the cath lab. The time it takes to get a patient to the cath lab who's resting usually mean their brain is not going to survive at the end. So there are places with so much experience that they're doing this in the field. And so the doctors are going out in cars. So in Paris, I just heard a podcast this morning that they're starting to do this in Australia and Melbourne. They do it in England now. So places where it's so congested, so hard to get patients to the hospital, they're putting these on the fields to protect the brains as the heart starts to recover. I mean, that would be fun. I would love to do that, but we'll see. But this cannulation is much easier. It's very quick. We can get someone on ECMO in under 10 minutes. When we're being slick, we can be in under 4 minutes. So that's while the patient's being coded. So while CPR is in progress, we put this on in the ER. And there's some things that sort of help us along with this. But our goal has been to not interrupt the CPR. So whatever benefit you get from CPR, and that's low, right? So patients who are resting in the field that come in have an extremely low survival rate. You still get survivor, right? But it's not huge. Even in the hospital, a patient who's having CPR has a 14% chance of survival. But that's still better than other stuff, right? I mean, it's better than letting them go. And so we don't want to interrupt the CPR. So we keep the CPR going while we're getting all these cannulas in. And this is what it actually looks like in person. So these cannulas are massive. So that arterial cannula in this person is a 25 French. So 25 French mostly means circumference. It's really 3 times the diameter. Because whoever came up with the French idea was too lazy to do the 0.14, whatever you get from pi. So a 25 French is a large venous cannula that trains the heart very well, partially occludes the vein. The arterial side of things on the other side, that's for us usually about a 17 French cannula, which is still big enough to partially occlude the artery. And so we added some stuff here. Can I make this go away?
What's that?
A box. That's right. So see this little white thing here? That is a angiocath heading down the leg. And so when the ECMO cannula is in the femoral artery, squirting blood up towards the heart, it is mostly occluding the femoral artery, stopping blood flow from getting to the foot. So one of the big complications is vascular compromise of the lower extremity. Whenever we put these things on, we put that down cannula in. So that's a 7 French cannula that's squirting blood directly from the ECMO circuit. So the same force we're sending to the rest of the body, we're sending a whole separate stream down to the foot. And before we transport anyone, we make sure that cannula is working well. So we'll wind up with an angiogram. If you're transporting someone to us, they won't have this. And so our one main referring hospital right now, we have them put in smaller cannulas. So they put in a 15 French arterial cannula, which should have enough perfusion to the foot till they can get to us. And then we put the down cannula in when they get there. So the cannulas go through the leg, but they wind up here in the heart. And so that venous cannula is right here in the picture, starting with the leg, but ending up here in the atria. So the tip of the cannula is sucking all the blood out from the heart. So this person had ARDS, horrible lungs, couldn't oxygenate, wound up arresting, wound up on veno-arterial ECMO, sucking the blood all out, filling with oxygen, squirting it back in the heart. This fellow made it out of the hospital, but he was on ECMO for over 2 weeks. It wasn't a huge deal. This is what one of those down cannula setups look like, slightly different locations. So it depends on where they can get in. So this cannula is also going downstream into the same artery that this cannula going upstream is in. That is a hard place to put it unless they're not arresting at the time. It's easy to get the down cannula in if this huge cannula is not in the way. And so when it's elective E, so someone who's been arresting and you get return of circulation back, then you can take your time a little bit, put the down cannula in to perfuse the leg, and then put the 2 big cannulas in up. Makes things much, much easier. If not, ultrasound guided the other way is sort of our new preferred way to go. These are those details for things. As you can see, the femoral artery diameters are small, and depending on the size of the patient, they're even smaller. So female patients have much smaller arteries, much more risk of limb ischemia. And then most of the folks who are arresting for cardiac reasons have arterial problems, right? So it's not just their heart, it's also their legs. They have bad perfusion to start with. Our worst problem with one of these distal ischemic things, the worst problem came with the transport someplace else, but the worst one we had in-house was his leg had such poor distal perfusion that even with that cannula in, the foot was still blue. So we moved the cannulas out from his leg, put the cannulas in his other leg because he needed the more pulsatile flow that the heart was providing. Then the other foot turned blue. So then we had to move the cannulas from there into the chest. So 3 different ECMO cannulations, all in the same person who survived and left the hospital, still had horrible peripheral vascular disease. There are places in the world that electively put it in. So they don't put it in everybody. We're not one of those places. The current thinking is this is like having a tourniquet on, having that catheter in place. Right thing to do if you're saving someone's life, but you have to be cognizant of how much time the tourniquet's up. So the bigger the cannula is, the longer that leg is being malperfused. And as that leg starts to die off, that could be the last straw for the person overall. So this is how we do it. We go with an ultrasound at a much better angle than that. That would never work. So you want to go in at 45 degrees for an angle. And so if it's 3 centimeters deep, and you start 3 centimeters back, so the needle comes in at a 45-degree angle, lets us cannulate the femoral artery directly, and that's the angiogram we get on everybody. So as long as you see contrast crossing the popliteal artery, which is this artery here crossing the knee, then you know you're in the right spot. And so this patient is getting perfusion into that artery down to the lower leg. This is, however, what we normally see where it starts to go away, right? So you should have 3 vessels here that go to the feet. This person's already down to 1. Same disease that caused the heart attack is the same disease that's causing the peripheral vasculature to be absolutely horrible. Veno-venous ECMO has none of the complications of distal perfusion, right? So with veno arterial ECMO, you're squirting it back into the artery. With the veno venous, you're taking out it from the vein, you're filling with oxygen, and you're squirting it back in. So that's a different type of problem. Because if I take the blood out and I squirt it back into exactly the same chamber that I'm sucking out from, I might just be recirculating the same blood through the ECMO circuit, and the rest of the blood is going the wrong way to the patient's body. And so today we have a fancier catheter called, I think Avalon, unfortunately, is a brand name. There's only one on the market as far as I know, so I'm not pushing the Avalon catheter, but it's designed so that there's 2 lumens in the catheter. And so you suck out from below and above. So you suck out from the inferior vena cava and the superior vena cava, and all the blood comes out through a side port of the cannula across the tricuspid valve into the lungs. And so it's a way of at least isolating the blood flow somewhat. Is it perfect? No. Is it much better than anything else? Absolutely. We've had people on an Avalon catheter who were awake and walking around, went outside, went to the window, it's tied to their neck. That patient unfortunately needed the VV ECMO, couldn't survive with just the oxygen, and wound up having a 2-week discussion with his family about what he wanted to do. Eventually he decided just to turn everything off. Without the ECMO, he wouldn't have had that time with the family. We'll talk about what kind of costs that involves to give people that kind of time. But that's what this is. This is the Avalon catheter. Starts at the neck, and it comes down, and that little thing squirts out blood. And on an echocardiogram, it's very easy to see where it's going, because on an echo with color, there's a huge line of red or blue heading someplace that's not the cannula. You just aim it towards the tricuspid valve, and it crosses. You can see it going to the ventricle. You just tie it there, and you leave it for the next month if you need it. This is the device you're going to wind up transporting with. This is the new $100,000 fancy ECMO device that is no better than the relatively cheap one we can put together in the hospital. It is just compact. And so there is that device up towards the top, which spins the blood out. So that puts the blood under pressure. This is a quadrox oxygenator. That's that fancy new artificial lung that gets the blood safely oxygenated while separating the oxygen from the bloodstream and not doing it in a way that destroys the blood cells. But they combine those two into this. And so both of those devices are built into here. You can pick it up, you can carry it. It gives you lots of interesting information. It tells you how much oxygen is being extracted from the blood. It tells you how much oxygen is getting into the blood. It tells you the speed. All of those things are entirely useless at a clinical standpoint. And it turns itself off if there's a problem. So if it detects a bubble, since it's squirting blood into an artery, it's worried about causing strokes. And so if you're a company and you have a device that might send a bubble to someone's brain, you design it so that it shuts itself off if it detects it. If you're on ECMO, you can't really stand for it to stop, right? And so we don't want that. So we have to turn all the alarms off whenever we transport one of these things, because the machine just can tell the difference in density of the liquid. And so if the density suddenly drops, it thinks I have a bubble. But if there's a bunch of IV fluid going by, the density drops, it thinks it's a bubble and turns it off. And so you can't start one of these ever without turning the alarms off first, which has been sort of an issue. So some places, like I came from Hershey, and so when they get one of these, they take it off and they put their kind of cobbled together one there because they don't want to get called all night with alarms that they can't do anything about. This is that Avalon catheter that comes from the neck. It's long, right? So it has to make it all the way through the heart to wedge itself in the inferior vena cava. And then you can't see the side ports on this view. You can't see the side port on fluoroscopy. You can only see it with an echocardiogram. You can do it with a handheld one at the bedside. You can do it with a transesophageal echocardiogram, either way. But you need something more than just an X-ray to make sure it's in the right spot. If it was entirely in the wrong spot, as long as it looks like this, you're still going to do fine. We did venous ECMO long before this catheter was invented. This is our other fellow. a guy I talked about who was 45 days into it, who was entirely dependent. He wound up with a trach, as you can see. So he was so stable that he was extubated, but couldn't clear his airway secretions because he was too weak. Wound up with a trach. He was in a trach collar here in this picture, so not even hooked up to a ventilator, just on the VV ECMO. Oxygenated fine, hemodynamics were fine, CO2 was fine, awake, telling jokes with his family, talking around his trach, but could never come off this. There's just no long-term support options for him. And he was in his 70s, so he was a lung transplant candidate. This is a bad picture. And so this is the last x-ray this patient ever had. That cannula doesn't go down, right? So this is where the inferior vena cava continues. This is where the tricuspid valve lives. This cannula is going through the tricuspid valve into the right atria and then out the right atria, and that's a fatal event 100% of the time. And so securing these cannulas is incredibly important. So we tend to put them in too deep and almost never too shallow. Too shallow always winds up with this. So who should get ECMO? Anyone you think is going to survive otherwise. And so there are papers written about who can get it and who can't, and feel free to read it. But the real question is, if the patient's heart and lungs were working for a couple of weeks, would they get better? Right? And that's sort of the question. So if you have a massive heart attack and your kidneys start to fail, you are in this horrible metabolic spiral where things just keep getting worse. ECMO gets you out of that spiral. So it lets everything else get better. So your kidneys get better, your liver functions get better, your lungs get better over time. If the heart can recover, then it was the right choice. If it's just the heart, you can get a transplant. If it's just the heart and lungs, theoretically, you can get a heart-lung transplant. That pretty much never happens. Or you can go to an LVAD and transition, or you can have time to make a decision about what you want with your life. So it's either a bridge to recovery, a bridge to decision, a bridge to LVAD, or a bridge to transplant. But we don't have any hard and fast restrictions for these kind of things, although there certainly are some out there. Yeah.
So how much time of semi-organ failure can you tolerate before you decide this is okay?
So it's all about the brain. And so as long as so witnessed arrests that immediately start with CPR, then we're fine with. If you've had significant downtime where the brain's not going to come back.
5-6 minutes.
Yeah, so if it's immediate if it's in the field, if it's witnessed with immediate CPR, we'll still give it a shot. Our numbers have gotten much worse because of that. So most of our transferred in ECMOs have had longer downtime than we would locally accept, but we've just agreed to accept all those things. But 40 minutes of CPR is certainly not a contraindication because we've gotten those people back plenty of times. As long as the circulation is good and the brain's being perfused, I don't have a criteria for that. If you've been on a ventilator for months where your lungs been getting worse and then you start to crash, that's a bad person to put in ECMO. If you have an underlying disease state, so you're dying of cancer, you've been sick for months and this is the next event, then those are the wrong people to put on. But you never know that beforehand. And so usually we're called that an unknown person is arresting and we need help with ECMO. And so we just put it on. This is our lung criteria, which is easier than our cardiac criteria. The cardiac criteria are always storing a code. And so we usually put the ECMO in and ask questions later. When your PaO2 is low on a ventilator, as long as you can get there quickly, and these are the folks that we try to get on fast, right? So we want to get their lungs better. The other part of your question, the last 2 ECMOs we transferred in, were too late to save their brain. So their CAT scans were horrible, but they had functioning lungs, they had functioning kidneys, they had a functioning liver. Both families donated organs. So it was something. I mean, it wasn't something anyone would ever push for, but still, it made it a little bit more worthwhile than it was. This is the cost for ECMO. And so if we just put it in, it costs about $20,000 to the health system. So that ECMO device I showed you, the $100,000 one, every time you put that in, that's $10,000 out of pocket to the health system for the cannulas and the disposables. The ones we make in-house is about $1,500 with the same results. So we put those in. We have one of those always available to wheel down and put one in. But then you have nursing costs, you have anesthesiologists that help, you have perfusionists that sit by the bedside, and so straight bridge to recovery is about $20,000. If it becomes futile, and we usually give everyone 3 days to see if they're going to have some neurologic recovery, because we'll do cooling for the first 24 hours to see if the brain's going to get better, then we rewarm over 24 hours. If there's no neurologic recovery and we think that's going to be futile, then we stop. But then we have this question about organ donation and the family wants to do that sort of stuff. If we go to a bridge to anything else other than recovery, the cost jumps up to about $500,000. Because that's long-term support, that's beds, that's transports, that's helicopter trips from here to wherever they do the heart transplant. So that's sort of the huge deal, and that's when all the conversations sort of come in. So these are the absolute contraindications, and this is it, right? So it's just for prolonged mechanical ventilation. You're probably not going to get better because you already have some kind of pneumonia. You're already so sick. Expanding intracranial hematomas. You really should be on heparin with these things. You can go 24, 48 hours with no heparin because the circuit's heparinized. But when you have an expanding hematoma, there's no meaningful chance of recovery for that sort of stuff. And if the underlying disease is immediately fatal, these are our only contraindications, right? So that means if you're coming into the emergency room and I don't know you, I don't know any of these things, you're going to wind up with ECMO. The relative contraindications, I had to put the smiley face there because this is central Pennsylvania, right? So weight over 125, not a contraindication. However, accessing a larger person during an arrest is much, much more difficult than accessing a thin person during an arrest, right? If you can't feel a pulse, you can't access the artery. You have to do that under ultrasound. Doing ultrasound during CPR is insanely difficult. And so our routine now is to make an immediate cut down. So we'll show up with headlights and loops and all that sort of stuff. And it's straightforward, just one cut down on the groin. There's training courses on how to just do this only. And you can see the femoral artery and vein and directly stick it with a needle. Not a big deal. That's what we did in our last person in the ER, but that person was huge. And it took 10 minutes to expose the femoral artery and vein. If you get both sticks in one, so both wires, both cannulas in the artery, or both cannulas in the vein, that's pretty immediately fatal. So that's the one part you have to be sure of. And so it's a relative contraindication, but really more about success than it is about anything else. I don't know if you want to hear any of this kind of stuff because I'm already going a little bit long, but let me just talk about a few things. So people who do lots of ECMO like to talk about this dual circulation idea. And since I had an iPad and I needed an excuse to use it, I drew some pictures. And so my very fancy cannula from the groin squirting blood up to the body, when the heart is not working at all, it's not ejecting any blood. So all the blood that's circulating to the body is coming from below, traveling up the aorta, and winding up to the brain vessels. So I am oxygenating that at 100%. I have great pressure, I have great flow. Heart doesn't eject, not an issue. As the heart starts to eject, as the heart starts to recover, it now competes with the ECMO blood flow. And so more deoxygenated blood or less oxygenated blood is coming out from the heart, coming from the native lungs. And that zone of mixing is a very dangerous thing, because now you have a patient that's starting to recover and things are starting to get better. Unfortunately, their brain is now getting worse and worse oxygenated blood. And that's when we start worrying about cerebral edema and cerebral swelling and long-term lack of survival. That first stop out of the heart, the first two takeoffs from the aorta are the coronaries. And so ECMO is not good for cardiac recovery. It is getting the worst oxygenated blood when you're coming from the leg. And so despite what you may think, replacing the heart, replacing the lungs, this doesn't promote cardiac recovery. This keeps the rest of the body alive while the heart recovers on its own. But fortunately, we have a few fancy ways to do cardiac recovery too. That second to last case is probably the worst situation possible, because all of the brain vessels are being perfused by the heart. Very little is coming from the ECMO. Nothing getting to the head has enough oxygen to keep the brain alive. So that's why we always test from the right wrist for arterial blood gases, because that's the furthest away from the ECMO cannula, closest to the heart. So what we can do is we can switch the cannula up until the axillary artery, because then we don't worry about the zone of mixing, because now we're sending blood directly above the heart. We can also centrally cannulate, which is what we tried to do with that last patient from the ER. We can put the cannula directly in the aorta and squirt blood there. Then you don't worry about mixing so much. But fortunately, someone came up with the better idea. When we did LVADs, there was lots of LVAD data that the earlier the LVAD went in, the more likely you were going to save the heart. So you get a big heart attack, but you offloaded it with a nice, fancy LVAD, $100,000 procedure right up front. Those patients had more heart recovery than patients who didn't. Because as you take the heart, it struggles to squeeze against the blood pressure. But now we have someone who's on ECMO. The heart ordinarily would have no blood pressure to squeeze against, right? Because it's failing. But now we're squirting blood up the aorta, and the heart's trying to squeeze against this machine. So it's actually straining more than it would otherwise. And so the idea is you want to offload the heart. So some way you need to get blood out from the heart, despite the fact that we're squirting blood up the wrong direction. So there's a couple things you can do. You can put in a balloon pump, because the balloon pump will stop the ECMO flow from hitting the heart as it tries to eject, right? So the blood's squirting up from the bottom, it's hitting the balloon, it's going to the kidneys, it's going to the intestines. And then as the balloon deflates, the heart ejects, the aorta is wide open, blood gets squirted through. Not great, not bad, data very marginal. You can imagine we're not sending great blood flow anyway with the balloon pump. You're occluding the ECMO flow sometimes to the brain, so not ideal. But there is this device, which is also one of a kind. And so this is the Impella, which for cardiac recovery is a thing that's best to offload the heart. It is a pump that sits across the aortic valve, and it squirts the blood out from the heart with a little propeller inside that tube, sucks it all out and squirts it back into the aorta. That is the best of both worlds. And so people are calling this either ECPella or IMPMO, depends on the country of choice. But the combination of Impella, which offloads the heart, and ECMO, which keeps the rest of the body alive, is a very nice combination. It is also the most expensive way you can possibly treat somebody, right? And so these are two hugely expensive devices, but once they're in, they both work relatively flawlessly. The other thing you can do is you can open up the chest and you can directly drain the heart with some vents, which is Pittsburgh's, the UPMC version of things. They like to centrally ECMO everybody. So they come in emergently with femoral cannulations. They go to the OR and they get central ECMO done. So the heart gets strained and the heart can recover a little bit better. None of these are wrong. Someday we'll know the difference. ECMO, this is their slide deck, has excellent data. And so we were once part of Cleveland before it became part of Pittsburgh. Cleveland is entirely ECMella people, because they believe in all this sort of stuff, with excellent cardiac flow and good recovery stuff. Pittsburgh is very much the other way, where they believe in open chests. I still really like this idea. So if you're not starting with an open chest, and you might someday be either transplant or an LVAD candidate, not doing open chest surgery, risking the chance of infection and scar tissue makes a lot of sense to me. So we're staying with Impella and ECMO for now. When we first did the transport talk here, we talked a lot of things about getting patients from there to here. And there was a lot of concerns and we were worried about a lot of things not working, but none of those things panned out. And so all the things we were worried about, what kind of ventilator we're going to put on, we had to make sure that the trucks had power. We had to make sure that we had trained folks. It turns out all the things we really needed to think about were this, right? So the transport monitors in the ambulances don't have the ability to look at A-lines, right? ECMO, when it's working for someone who's in heart failure, has no pulsatile flow. A blood pressure cuff does absolutely nothing for you. There's no Korsakoff sounds, there's no oscillations, there's just ECMO. So they needed an A-line, so then we wound up started to bring our ICU monitors down with us. And then we were concerned that the patients would have transiently low blood pressures. And so these patients going on ECMO have metabolic derangements. They just had heart attacks. They start to crump, and it takes a while before they get better. But the first thing your body does when things go bad is it vasodilates and your blood pressure drops. So then we needed to have drips that we weren't necessarily thinking we would need for transplant. So we needed vasopressin, we needed epinephrine. We needed people who were used to doing these things on the pumps that they were going to be on. So then we wound up sending an ICU nurse down too, because they just had that, right? So it wasn't a big deal. They just stuck their 2 syringes in their pockets that they carry on all the time. They go down, they come out for the transplant, transport, and then they wind up being that patient's nurse for the next 2 or 3 days. It's been a very effective sort of thing, but Epi and Levofed have been our things, and both of those have nothing to do with how well the circuit works or the rest of the body recovers. This is entirely about that cerebral protection stuff, because you need to keep that blood pressure up as the brain starts to swell after all that stress. If the blood pressure gets too low, they get worse neurologic recovery. So this is why we still die on ECMO. Lower extremity ischemia. So our goal to prevent that is everybody gets a down cannula, no matter what size your artery is or what size cannulas we put in. Strokes and neurologic complications are 100% of our current mortality. Every patient we've had die from ECMO has died because of neurologic reasons. Acute kidney injury is a real thing, but the ECMO circuit sucks all the blood out and squirts it all back in. While it's out, we just dialyze it too. And so we hook up our dialysis circuits right to the ECMO machine. And so as the blood's taken out, we throw it all back in, no extra lines, no extra tubes, no extra complications. And so for us, at least, a kidney injury has not been our Achilles heel. Major bleeding has. And so, you know, patients are moved, they get turned in bed. Those large cannulas, if they move in the leg, can cause huge retroperitoneal hematomas, especially long-term when they're on anticoagulation for 12 days with those large cannulas in. If you don't turn the patients, they wind up with huge bed sores. So you have to do that. But when you do it, strict log roll precautions, but even with that, we still had plenty of blood transfusions. And then even though these machines are designed to be gentle to the blood's torn apart all the time. So they wind up with 1 or 2 units of transfusions a day, every day that they're on ECMO, unless they're perfect and really starting to get better. So they wind up with a whole bunch of blood and all the complications you can get from massive blood transfusions. ECMO is almost never put in sterilely, right? So imagine any central line, big central line that you're going to put in the field that can't get taken out for any reason, or else the patient's going to die. We have plenty of infections, so we give them all ANSEF for a couple of days, and then we just watch. And if anything bad starts to happen, then we deal with it. Never had to take out an ECMO for an infection reason, but we certainly had plenty of pneumonias, probably more than anything else, because these people are sick and aspirating and all that sort of stuff. So this is the same stuff we've had. So how does ECMO do? There's a national database called ELSO, which we're not part of, because you have to pay for that. You have to have a database manager, and we really should be. But Hershey wasn't part of ELSO, and the guy who started ELSO in Germany came to Hershey, so he's the guy I learned from. So I just never felt we needed to go that route, but we probably should someday. In general, nationally, it's about 50-50 for survival to discharge for someone who goes in ECMO. And these are patients that start off with an 80-20 against them or worse, or someone who's coding in the hospital. So if you imagine a coding in the hospital patient who has less than a 14% chance of survival for one arrest, and the second arrest, it drops to about 1%. Now they're up to 50-50, which is pretty good. Pulmonary rates are better, especially H1N1 was excellent. That's really where ECMO started taking off. This was a great way to support people until they got over their infections, because the rest of the body was okay. It's just everyone died because they couldn't oxygenate during the course of the virus, and that was good for us. We've had plenty of those folks. As I said, looking at what makes a difference is early time to reperfusion, right? So keeping the brain alive. And so this is real folks in real places, the real world, crashing people at ECMO. They put the cannulas in, they secure the cannulas, and then they leave and they go do it to somebody else, right? So they're not even there for the transport back to the hospital. That would be the goal ultimately, but the question is, when's too soon for this? So if someone is going to make it from your field CPR and we early take all the good ones to ECMO, then you'll have good results, right? But some of those people might have made it anyway without this, and so that is not answered yet. So the current thinking in this country is 16 minutes. Those are the places that do this in the field are doing CPR for 16 minutes, and if you have no return of circulation in 16 minutes, then they put them on ECMO, which is their window, and we'll see if that pans out okay. Unfortunately, the folks who recover best from ECMO have shockable rhythms. And so people who are asystolic and are probably not going to get better after your resuscitation anyway, don't necessarily get better after ECMO. And we don't know why yet. Our data we've been collecting since 2014, and I can show you all our data up until we started this stuff with the transports in, because none of our transported in patients have survived, all for neurologic reasons. Although the catheter placements have been excellent, we've had no vascular complications whatsoever. As a matter of fact, we probably transfuse those patients less than we transfuse our own patients, because they're starting with relatively small things and they're well secured. But for our in-house patients, at least, we started off with a 63% survival, which we were happy with because that was better than 50-50. And then for 2016 and 2017, we were at 88%, which I was happy about, but that just means you're not putting in enough people, right? So we were being overly selective. And so I'm not saying that the goal is 50-50, but if we're having an 88% chance of survival, then we're either putting in people who are too healthy, because we're not better than everybody else in the country, or we're ignoring some people that were on the brink that maybe we could have saved. And so we actually took this 88% number and expanded our indications for who gets it. So I'll let you know how that works out for us once we figure out this whole transport in thing. Questions?
The neurological strokes themselves, mostly hemorrhagic, I would assume.
It's almost all been cerebral edema. And so it's, there's no walkie-talkie patients in ECMO. So they've all arrested. They were all unresponsive to start with. So then we now have return of circulation. We have return of kidney function, and the liver functions are getting better. The hemodynamics are okay, but they're still not waking up. Those are the folks that just have so much cerebral swelling. And then it's a hard discussion with the family because now they have someone who looks pretty normal. So they're on this machine, but their blood pressure is stable and their heart looks like it's recovering, but they're not waking up at all. That's really what we've been struggling with. So the way EVAN is doing it, which I still support, is that they've taken everyone to the cath lab. So they're taking someone who is on a Lucas for up to an hour, and then bringing them to the cath lab and putting them in ECMO. And once they go in ECMO, everything's better. So their blood pressure is great. They start making urine again. Their liver functions are getting better. Still wasn't enough for the brain survival. Thank you very much.